دلوقتي ولا كده خلاص؟
Now we start the Roche-sponsored presentation by Professor Imam Waked. HCC diagnostics beyond ultrasound and alpha-fetoprotein.
Bismillah ar-Rahman ar-Rahim. This talk is sponsored by Roche. I'll talk very briefly about diagnostics beyond ultrasound and alpha-fetoprotein. ممكن السلايدز presentation. مين اللي بيشغل يعني the aim of all HCC screening and diagnostics is to detect early stage HCC. Ultrasound as a single diagnostic agent in early stage sensitivity is around 45%. If we combine ultrasound and alpha-fetoprotein, sensitivity for early stage increases to 63%. This is fair, but this is not perfect, so we need better diagnostics. I'm going to talk in some limited detail about PIVCA and alpha-fetoprotein L3 and some combinations. PIVCA is the precursor of prothrombin. It's called protein induced by vitamin K absence. Prothrombin precursor is initially synthesized as a protein that contains 10 molecules of glutamic acid. With vitamin K in the normal liver, these glutamic acid molecules are gamma carboxylated to produce prothrombin from the prothrombin precursor. If vitamin K is not present, and in HCC cells which cannot utilize vitamin K, there is no gamma carboxylation, so the protein is produced without the gamma carboxy glutamic acid molecules, so it's called this gamma carboxy prothrombin, or protein induced by vitamin K absence. So this protein is produced in cases of vitamin K deficiency, vitamin K antagonists, or in HCC, because HCC cells cannot uptake vitamin K and utilize it. PIVCA as a marker detects more HCC cases than alpha-fetoprotein. This was an initial trial in Germany, China, Japan, and Thailand. 168 cases of HCC versus 208 controls. These are the ROC curves for the PIVCA for all HCC, early stage and late stage. So there is a perfect separation. PIVCA detects more cases of all HCC than early stage, and using a cutoff of 28.4, using the Roche Elexis autoanalyzer, the PIVCA2 showed high sensitivity combined with good specificity. And this is the scatter of the alpha-fetoprotein and the PIVCA in these cases. At a cutoff of 20 for alpha-fetoprotein, the sensitivity was rather low. 52% of cases were detected, or 87 of the 168 cases, and 81 cases were missed by alpha-fetoprotein above 20. Using PIVCA at a level of 28.4, only 22 cases were missed, and the sensitivity increased to 87%. And combining PIVCA and alpha-fetoprotein, this increased the sensitivity further to 92%, and only 14 cases had normal alpha-fetoprotein less than 20 and normal PIVCA. So if you combine them in an autoanalyzer, you will detect more cases of HCC. And this led to the development of a score, the GAD score, which combines the gender, age, alpha-fetoprotein, and the PIVCA, or this gamma-carboxy prothrombin. And using the GAD score, the age, gender, and the two biomarkers, the sensitivity and specificity was higher than alpha-fetoprotein alone. So you can increase the sensitivity of detecting HCC by combining gender, age, alpha-fetoprotein, and PIVCA. Alpha-fetoprotein L3, the alpha-fetoprotein usually is separated into three different glycoforms, L1, L2, and L3. L3 is the one that's bound to the lectin fraction, and it's only produced by cancer cells or HCC cells. It's very highly specific for HCC, and it can usually produced by early tumor cells. So this led to the development of what is called the GALAD score. The GALAD score is a combination of gender, age, alpha-fetoprotein L3, alpha-fetoprotein, and this gamma-carboxy prothrombin or PIVCA. The data are entered into a formula, a very complicated formula. This is the formula to calculate the GALAD score. And after the score is calculated, it enters into another formula to calculate the probability of HCC in a given patient. So they are developing an autoanalyzer to automatically calculate the alpha-fetoprotein L3, the PIVCA, and enter the age and gender into the formula and get the GALAD score. You can calculate the GALAD score for a patient using several calculators online, the Mayo Clinic calculator or the MD Calc calculator, and this allows for early detection. This is image of one of the calculators. This is the Mayo Clinic calculator. You enter the gender, age, the level of the alpha-fetoprotein, the percent of the alpha-fetoprotein that's lectin reacting or alpha-fetoprotein L3, and the level of the PIVCA. And in this case, with these figures, the GALAD score was 3.3, and the probability of HCC in that patient was 97%. So this is being developed by Roche in an autoanalyzer, and it received FDA breakthrough device designation 2 years ago. It's not yet available commercially. But it has been validated in many studies. The first study, or the developer of the GALAD score, was Philip Johnson in Liverpool. He published his first report in 2014 on using data from 670 cases, and the area under the receiver operating curves for the GALAD was 97%. This has been replicated in other studies. This publication from Germany, the area under the ROC curve was 92%. This was a validation study from several countries, from Japan, China, Taiwan, Germany, and England. The GALAD, the ROC curve was 95%. In Italy, 98%. And in a more recent study in the United States, the area under the ROC curve was 95% for the GALAD, compared to 82% for the ultrasound. And if you combine ultrasound with the GALAD score, the area under the ROC curve increased to 98%. That's in detecting HCC. What do the guidelines say? The AASLD guideline is recommending ultrasound with or without alpha-fetoprotein every 6 months. The European guidelines recommend ultrasound only and no alpha-fetoprotein. However, all the Asian guidelines recommend using alpha-fetoprotein and ultrasound, and the Japanese guideline use PIVCA, alpha-fetoprotein, and L3, the three biomarkers, with the ultrasound every 3 or 4 months, in addition to CT and MRI every 6 to 12 months. And there is another Japanese guideline that's recommending alternating ultrasound with MRI once every six months. What are the future directions? very quickly or very briefly the use of serial alpha-fetoprotein. The rate of change of the alpha-fetoprotein is very significant. And in this publication from Italy, they found that patients who had stable alpha-fetoprotein for a very long time, if the alpha-fetoprotein starts to increase above 7, this indicates that they are going to develop HCC. And in these HCC patients, they found that the alpha-fetoprotein increased above 7 1 year before detecting the alpha-fetoprotein. So following up the alpha-fetoprotein is important. Imaging studies, alternating CT and ultrasound every 6 to 12 months, or using MRI instead of ultrasound is more diagnostic. And there is radiological use of abbreviated MRI, a very short sequence MRI that's directed only to the liver. And in meta-analysis, it had better diagnostic than ultrasound. Other biomarkers that can be used in the future but are still in research, using microRNAs, liquid biopsies to detect circulating tumor cells or tumor DNA, or methylation products. All these are coming in the future. So in summary, PIVKA2 is elevated in most cases of HCC. It provides complementary information to alpha-fetoprotein. Combining PIVKA and alpha-fetoprotein increases the sensitivity. The alpha-fetoprotein L3 is a specific marker for HCC, and when you put them all in the GALAD score, this increases very much the detection rate of HCC. And if you combine the GALAD with the ultrasound, probably this would be the future. The GALAD ultrasound or GALAD-US is a future marker for HCC. And thank you very much.
Thank you very much, Dr. Wackett, for this excellent presentation. And I would like to start having a question for you. Of course, when we are talking about screening, we are talking about two important issues, which is how much we can save, we can early detect, and of course we can save, number one, life and money. So I would like to ask you if there is any studies in this issue regarding these new biomarkers. Is it worth to go for? Is it cost effective or not?
Well, these biomarkers are not new. These
Yes.
biomarkers are more than 20 years old.
I mean the GAD and the GALAD.
The GALAD score, the score
Yes.
is new, but the biomarkers, the PIVKA and the alpha-fetoprotein are more than 20 years old. There was a Japanese machine that can test for the 3 alpha-fetoprotein, L3, and the PIVKA automatically 15 years ago, and it's still available. And most of the studies that were presented here were done using the WACO or the Japanese machine. Cost effectiveness depends on the price. We don't know the price. We don't have a price for the automatic analyzer. Using automatic analyzer to calculate the score or the GALAD score. However, in Japan it's very cost effective because they're using it a lot, and in China they're recommending its use. When they come to Egypt, we have to calculate the cost to see if they will be cost effective or not. But when we studied ultrasound plus alpha-fetoprotein, it was very cost effective. So probably these will be cost effective if we can detect early HCC.
Thank you.
Thanks very much, Professor Imam Wackett. For high-risk patients with advanced cirrhosis after HCV, regarding MRI surveillance, especially EOP MRI, is it cost-effective to adopt this screening? Because you know the ultrasound alpha-2 sometimes miss many patients. Thank you.
Again, it has to be the cost effectiveness has to be calculated. The risk stratification of HCV patients after cure is a valid concept. Professor Shiha has published a lot on this. We have validated his algorithm in the National Liver Institute, and we have validated the algorithm further in several countries, in France, in Japan, in Spain, and in the US. So you can stratify risk, you can select high-risk patients. Whether using MRI would be effective or not, it needs to be studied in a prospective trial.
Any question from the floor? Thank you, Professor Imam. And then Professor Mohammed Abdel Fattouh, Roche sponsored presentation. تفضل دكتور محمد.
أولاً بشكر organizing committee for inviting me to do this talk. This talk is sponsored by Roche. I'll talk about the era of immune therapy in unresectable HCC. The rationale for immune therapy in HCC, we do that because the liver has a high mutational burden, and this can generate new antigen that can initiate cancer immunity. Throughout the years, this is a timeline for treatment development for HCC. Until 2007, we started to have the sorafenib with the famous SHARP study, and we waited for 10 years more to get the lenvatinib through the REFLECT study as non-inferior to sorafenib. And till 2019, we started to have the immune therapy to play a role in HCC with the famous EMBRAVE 150 study with atezolizumab and bevacizumab in the management of HCC. And recently we have another immune combo through the Himalaya study with the tremelimumab and durvalumab, and this just approved as first line also in HCC. Why we combine anti-VEGF with immune therapy? Because HCC is a very vascular tumor, and VEGF factor alpha is expressed in HCC, and the gene amplification was found in 48% of HCC cases. This will result, this is important for new angiogenesis, and with the tumor growth we have hypoxia. Hypoxia will induce HEF1 alpha. HEF1 alpha will stimulate VEGF alpha, which is essential for angiogenesis. And also the high expression or high VEGF alpha in the tumor will have impact on the immunity. It will do immune suppression through increase of T regulatory cells, and also with increase of myeloid-derived suppressor cells. Also, it will decrease the tumor infiltration with lymphocytes through decrease of VCAM expression on the endothelium, and also increase fast ligand expression on the endothelium. It also will reduce the immune activation through a decrease of dendritic cell maturation. All this will lead to decrease in the immune response to the tumor. The rationale to combine both, if we have a monoclonal antibody to attack the VEGF, then we will reverse this process, so we will have more tumors T cell infiltration, we will decrease Treg and myeloid-derived cells, and we will have maturation of the dendritic cells. In combination with PD-L1 antagonists like atezolizumab, this will promote T cell activation. Both together will increase the immune response to the tumor. The EMBRAVE 150 study, this is a study design, was for locally advanced or metastatic unresectable HCC with no prior systemic therapy, including just more than 500 patients. The randomization was 2-to-1. The endpoint was combined endpoint with overall survival and the progression-free survival by independent review facility. This is the inclusion criteria. This is the patient characteristics in both treatment arms. There was no difference between the two arms. please note that most of the patients were child A. Actually, more than 99% of the cases were child A, and less than 1% was child B. And extrahepatic extension or major vascular invasion was present in 77% of the cases. And most of the cases, in 82% of the cases, were BCLC. So this is the efficacy. We have seen unprecedented response in HSC. We have 30% response between partial and complete response, and for the first time we saw complete response in 8% of the cases. This is compared to 11% overall response rate in the sorafenib arm, with less than 0.6 complete response, and longer median duration of response with the combo is 18 months versus around 15 months, and the 12 months overall survival was 67% compared to 56%. This is the first analysis. They showed that this was published in 2020 New England Journal of Medicine. The overall survival, the median was not reached at that time, and for the sorafenib arm was 13.2 months, and the progression-free survival was 6.8 versus 4.3. In the updated analysis presented in the ASCO GI in 2021, the median was reached for the combo, and it was 19 months compared to 13.4 for the sorafenib. And this is the forest plot analysis. It showed it favors the combo compared to sorafenib, except for the patient with non-viral HSC, which was better with sorafenib compared to the combo. And this is the progression-free survival was maintained with the new analysis in 2021 with 6.9 compared to 4.3, with a hazard ratio of 0.65. That means that we reduce the risk of progression by 35% with the combo compared to sorafenib. Again, this is the forest plot. It favors the combo compared to sorafenib in all patients group. The safety analysis, grade 3 and 4 adverse event was in 36% of the cases in the combo arm compared to sorafenib, 46%, and grade 5 toxicity was 5% compared to 6% for the sorafenib. And adverse event leading to withdrawal from both component for the atezo-bevo arm was 7% compared to 10% in the sorafenib arm. This is the, as all anti-angiogenic agents will have some bleeding tendency, but most of the cases were trivial. You can see here most of the cases were epistaxis, and there is no grade 3 and 4 epistaxis. Very few cases with esophageal varices and gastrointestinal hemorrhage in the Avastin arm. This is the main side effects in the sorafenib, mainly was diarrhea and BBE, and for the combination arm, mainly was hypertension and proteinuria. Quality of life, there was a better quality of life with the combination arm with a hazard ratio of 0.63, and median time for deterioration was 11.2 months compared to 3.6 months. And this is again was for the physical domain of the quality of life, was also significant for the combination, and also for the rule function domain. We have better results with the combination compared to sorafenib. And this is the IMBRAVE conclusions. Overall survival, we have a hazard ratio of 0.66. That means we have 34% reduction of the risk of death, and 35% reduction of the risk of progression. And there was a clinically meaningful improvement we're seen in the overall response rate, and the response rates were more durable with atezo and piva. Treatment deterioration of patient quality of life was delayed with the combination compared with sorafenib, and the safety and tolerability profile of atezo and piva was in line with the non-safety profile of each drug, with no increase in the toxicity. This one important thing is how to select your patient. Patient with unresectable or locally advanced. Please note most of the patients with the study were child A. That's very important. And HC not amenable for treatment with local regional or surgery. Also, hepatitis B patients should have a DNA less than 500 international units per ml within 28 days before from the study, and HIV treatment for more than 14 days prior to initiation. The EMBRAVE exclusion criteria with significant cardiovascular disease within 3 months of initiation, or active history of autoimmune disease, or untreated or completely treated varices. This is because we have a higher incidence of bleeding if we have varices not treated. This mandate that the patient should have evaluation. Should be evaluated for varices within 6 months prior to start. This is the ESMO guidelines showing atezo and piva as first line. And this is the newcomer in the immune therapy, what we call the Himalaya study. This we have a tremelimumab plus durvalumab compared with sorafenib, and the results showed that it have overall survival advantage over sorafenib and median progression-free survival advantage over sorafenib. And this is the BCLC 2022 showing included the plus atezo-piva. They included also durvalumab and tremelimumab as first-line treatment for HC patient. This is what is going to happen within the next few days. We have a lot of combination treatment with TKI and the immune therapy and combined immune therapy for the treatment of HC. This is highlight the importance of a multidisciplinary team in the management of HSC. And by that, I would like to thank you all for your attention.
Thank you very much, Professor Mohammed Abou Fatouh and Professor Imam for Roche-sponsored presentation. Because we are very short of time, the break will be 7 minutes.